We're very privileged. This panel is going to be moderated by Tiffany Duvernay-Smith, who is a systems reform champion and coming on up. We also have, and just come on up in any order once you're mic'd, and I'll just announce you. We have Brett Feldman, who is the director. He's a co-founder, USC Street Medicine. He's an associate professor of family medicine. And, you know, street medicine has been a national movement, very exciting. We're honored to have him. We have Dr. Graham Rosenberg, who is a board certified cardiothoracic surgeon, assistant professor of clinical surgery at USC Keck, who has been leading a charge to improve the lives of thoracic surgeons through performance science. And so we'll get to hear about that. We have Dr. Ryan J. Smith, president and CEO of St. Joseph Center, who also I mentioned, yeah, absolutely. Yeah. And I mentioned definitely someone who said St. Joseph's, you know, what'd they say? On the west side, what'd you say? Repping on the west side? Yeah.
West side is the best side.
Yeah, absolutely. And also they catered the day, as we know. Yeah. Their Bread and Roses Cafe. And we're very excited to have Swaba Swayamdeepta. Swaba is an assistant professor of computer science at USC. She's also the co-director of one of the most exciting things going at USC, which is the Center for AI and Society. AI is something, obviously, I'll let her talk about it. But a huge deal. Our main overarching conversation here, we're still on this big how. What is the how of flourishing and empowerment being implemented in the county system? What have we missed so far today? We have a very diverse, very brilliant panel here, and hand it over to our brilliant moderator, Tiffany.
Here we are. It's the afternoon. I appreciate everybody who is still in the room. So give yourselves a round of applause. Yep. So I'm going to ask a couple of overarching questions. And the first question, I want you to think in terms of, I don't know if you've ever heard the phrase, there's levels to this. So there's levels to this, like research, practice, and policy, okay? So how can leaders, because you're leaders, you can speak personally and broadly, right? So I'm asking you, how can you? But it's really how can leaders sustainably advance flourishing on research, practice, and policy levels? And let's start with someone. Is there anyone who's been here since the morning? Wow. Okay. Well, when you think of flourishing and thriving as synonyms, I'll just give you that. And empowerment as the how to get folks to flourishing. And we're thinking in terms, definitely participants, people that were served, and also the frontline workers who are helping them, who are possibly either being re-traumatized or experiencing vicarious trauma, secondhand trauma. And this is a layer of the sector that needs to be flourishing to help who we're helping to flourish. So this is the line of thinking that we're in when the question is asked about flourishing on a research level, on a practice level, on a policy level, in order to impact the front line and the people that we're serving. Who would like to go first? Swaba, putting you on the spot.
Okay, I am, very glad to be on this panel, and for most purposes, maybe a little bit of an outsider. My background is computer science, and I have been involved with some research through the Center for AI and Society. The director, Eric Rice, is somewhere over there, in research where we try to use AI to understand how people feel about homelessness, the broader population feels about homelessness. So in the context of that line of work, my couple of cents are that like research, practice, and policy thrives when researchers interact with the community, where we are not just, taking these big technologies, which are kind of like very popular, very hypey right now, but we can't just take those and just, throw that at some problems, thinking that whatever the solution is will just magically appear. We have to really talk to the community. We have to interact with them to find the best solutions, to understand where, this kind of technology can help the most, and take that back to the policy question where we talk about like what are the benefits of certain technology being applied to these problems, as well as what are the harms of applying technologies such as AI to problems that affect real human beings. So I will just keep it at that for now.
Thank you.
This is, practice, policy, and research. Okay. So for me, I do street medicine, which is healthcare on the streets, under the bridges, wherever people are. We go to them and deliver care in their environment. And so for me, this starts with the practice. And what would be like the opposite of flourishing for us would be a sense of disempowerment or a sense of futility, that no matter what we do, nothing will help. And so when we go out onto the streets, what I've found is that the people actually continue to encourage you. It's the system that gives you this sense of futility. And so you're on the street and you get so frustrated, and you have like a sentence that always begins with, why can't I just fill in the blank? And so that's where it starts, under the bridge. And then you have to build the policy and the research back from what you experience. So when we go outside, we see things that we can't unsee. And in seeing those things, you become a witness. And as a witness, you have a duty to come back and tell the policymakers what it is you're seeing under the bridge, because they're not under there with you. And research helps you tell that story. And what I've found, because we have so much experience now under the bridges, that when you see research that is contrary to what you're seeing, you question the research. I know what I see. And so it usually serves to, I don't know if validate is the right word, but validate our witness story. And we're not telling their story, but our story as witnesses to what they're going through.
I love
Say that again. So the validation, your story is validating?
No, the research helps to support what we've witnessed.
Okay.
So like if I know, for example, I'll give you an example.
I understand. So the real life experiences plus the evidence-based data are matching and complementing each other?
Complementing each other.
You think so?
Is that so? I'll give you an example. How about that?
I'll give you one too. Okay, go ahead.
Okay. So a lot of people have insurance. About 85% of our patients are insured.
Okay.
And our experience is that almost nobody is seeing their primary care provider, who's getting paid by the insurance companies to see them. And so we spend a lot of time trying to get them to their PCP who has never seen them, and we just want to treat them on the street. And so when we do research, we went out onto the street and we asked the people, how many people have insurance, how many people are seeing their PCP. 85% have insurance and only 7% saw their PCP. So it put a number to what we knew we were seeing.
I got you.
Yeah.
And then what I would lift up is if you listen to like a tenant advisory council, for example, or if you listen to people who have come through the system and they're now housed, maybe they found their voice and they advocate for themselves and where they are and for other people in their building, you'll find that the quantitative data that gets the funding and what people think are happening is not what's really happening, or there wouldn't be so many complaining and talks about barriers amongst people who are in permanent supportive housing. For example, you may have a senior who has experienced a couple of SWAT team raids in her building. How traumatizing is that? You're 70-something years old, recovered decades ago from alcohol and drug abuse, but you smell the drugs, you see the drug dealers, you see the SWAT team. And so a certain place may not be conducive to someone who's disabled, who's recovering from substance use or has recovered, and who may be a senior. This is not the ideal place for them, but their voice is not heard. And a lot of people's voices are not heard from what they're actually experiencing. And I know it's because we're in a crisis and it's just house. But what they're saying is like, I'm not flourishing. I'm not flourishing because of this, because of this, because of this, because of that. The phrase democratized research is where you do bring in the qualitative data, the actual person with the experience, to the lining it up, trying to make it match to what you were just saying. So good analogy for you, and then I had one on my side. Okay, same question for Ryan and Graham.
Well, first of all, I just want to thank HPRI for the opportunity to be here. By the way, I have known this young woman since I was 15 years old. I'm aging forward and she's aging backwards. So I feel like there's a full circle moment in that. But I really do, to your point, really believe in the democratization of data for people. Like, how do we actually use research and data to drive practice? And oftentimes practitioners are never at the table in policy discussions, are being, the work that we do is studied and not actually done in actual partnership. So that's why I value HPRI, because they actually do think about how we partner with folks to get stuff done. Well, there's a couple of things I am thinking about practice in this moment. One, St. Joseph Center, we're celebrating our 50th year anniversary next year. Okay. Started by some amazing social justice sisters who took classes at St. Bernard's and said, we can't just study this, we have to be about it. When I say sisters, I do mean nuns. And they do text me. There's still an order that texts me every week to hold me personally accountable. And now we support 15,000 people across LA County, on the west side, but also in South LA and downtown. And our work is really centered. It is human centered. So when we think about flourishing, we have to think about the humans that we work with. I'm excited because you all got to take a taste of Bread and Rose's training kitchen. That program's been around for 35 years. To take people who've experienced homelessness and making the future culinary artists and folks who are doing our amazing chef work. Please give a round of applause to Ariel and Sharon and Kim and Angel, the amazing women who have worked tirelessly to make this happen, because they really understand like the value and the importance of how love and food are really centered. I think about the 400 men and women who work and folks who work at St. Joseph Center. 68% of them have experienced homelessness or have been system impacted. That's Sharon, by the way, everyone, who actually does all of our work. all of our workforce development work, 68% of them have experienced homelessness or been system impacted. So the people most proximate to this work are helping to address it and end it. But I will say this, I've been at St. Joseph Center for 18 months, and it is the most beloved community I've ever been a part of. I have never seen folks who, now we have our issues like every family, but you have folks who really care for each other, have stayed at St. Joseph Center for 8-9 years because they are partnering with folks. Yes, they've been traumatized by the work. They are tired, but they really believe that it's because of this collective of people that we can actually address this issue. Part of the framework around flourishing is about celebrations. And I just want to take a moment to celebrate the amazing staff that I get to work with every single day. We're really moving the needle of the work. If you do work for St. Joseph Center, can you raise your hand? I appreciate you.
I kind of work there.
I'll also say that 55%, the majority of our staff are Black and brown. 55% of our staff are Black. 55% of our workforce graduates are Black in a moment where we're seeing Black jobs really attacked. So I just have to celebrate the success of my team.
Okay, Dr. Ryan Smith, how can you sustainably advance flourishing on a research level, a policy level, and a practice level?
So we are on the research and policy level. We are developing we think of our work as actually the intersection of policy, practice, and system change. At the end of the day, some people think about how we scale work and sometimes market share. How do we grow? But I don't believe we need to talk about growth in this moment. In fact, we really can't because of the resource constraints. What we really need to do is take the good work of Thomas, who works in our outreach team, folks like Sharon, who runs our workforce development, and say, how do you codify what they know, what they've been doing for the last decade? How do you share that back out with the field? We often think of researchers as the people who should be doing that, but it's really the Thomases and Sharons of the world who should be informing practice, and certainly in this moment, informing policy. As we know, whether we're talking about the Olympics or other world events happening in Los Angeles, or you talk about the devastating kidnappings that are happening on the streets, or you talk about even the profiling that obviously is expanding under this administration, like it's these people who need to share their stories and their experience and how we can move the needle in order to inform policies and fight the policies that we see coming down the pike. So how do we create space for more storytelling? How do we create space for more tables and discussion for lived experts? How do we make sure that the policies that we have right now are in place don't just ask us for feedback? What do you think about this? But they're asking you, Tiffany, what policy should we inform? And then in the back end, when we're trying to evaluate what we're doing, they're actually listening to you and say, this isn't working. We need to change this. These feedback loops and things like that don't necessarily happen in practice. But now is the time to really double down on listening to the people who are in the front lines. Exactly. Because attack on community right now is real. So now is the time to create space to hear even more so from community as people are trying to dismantle it.
Thank you very much. And I want to tie this in to something that's already said about almost nobody taking advantage of their healthcare benefits, right? Sorry. I forgot how I was going to tie it in. But I just want to mention a solution. Does anybody know about health navigation? I want you to know, I'm going to go back like 10 years and be sure that you know that certified peer mental health specialists, this is pre being able to build Medi-Cal, right? The certification given by DMH was a prerequisite for health navigation training where people like myself were trained to walk with someone for 6 months. So we're going to talk about the mental health community for a second. This is a community where statistics say this group of people, this population is passing away 25 years earlier than everybody else. And so the health navigator is to help someone focus on their mental dental, and vision benefits. This is like a hand walking, like if you have fears, I'm gonna be in the waiting room with you. This is, you've already done an assessment on this person, maybe you go with them in their appointment, being sure the PCP is close, but hand holding them for 6 months. And if they need it for a year, you do it for a year. But LA has not made the most of the health navigators, whether you continue the training or put them out here in the work to do what, it's not really the case, it's not the case manager's job to go to your doctor's appointment and find out, you know? Using health navigation. And what you just said proved that there's a space. We already know there's a space, but what you said proves that there's definitely a space for the health navigation. And then also lifting up building policy from what we experience is something else that was shared. You just put your stamp on that. You know, are there policy analysts in the room today? Are there legislative people in the room today? Because there's a space for that too, right? Don't you want to hear from the frontline workers? What would make you flourish? You hear from people who are formerly homeless. How did you flourish? But who's going to be in the room listening to those conversations? It better be the policy people who can build a policy from the ground up. I don't need to give you input on a policy. I don't need to give you feedback. I don't need to look at your draft. Start with the conversation. And I know if a policy person was sitting here in here today, they could build a policy on what they have heard us talk about on this day. What do you think about all of this, Graham?
Well, first of all, I want to thank Seth for inviting me here. It was a surprise invitation. Seth and I were connected through some collaborators at Public Exchange at a Dornsife at USC. We had a great conversation about some of the stuff I'm working on in healthcare and the correlations there were with the lived experience of people who are experiencing homelessness. Now, to give a little bit of context to that and then inform where I'm going to go with your answer to your question, I want to take a second and point out that many clinicians, especially those who are young in training or new into the workforce, have also not seen their PCP, right? I didn't see a dentist for 9 years when I was in surgical training. I didn't go to my primary care doc. I probably need to still make an appointment because the reality of the fast-paced, commercialized world of healthcare that we live in is that many clinicians, and I'm including nurses, surgeons, doctors, allied healthcare professionals like PAs and nurse practitioners, they defer taking care of themselves in order to take care of their patients, right? And over a long period of time, that comes at a cost. Chronic health conditions are higher in doctors than the general population. Suicide rates are higher than most, if not all, other professions. Musculoskeletal injuries, divorce rates, substance abuse. And while many people in the community hope that their surgeon is showing up ready to go, right? The reality is that is not always true. Sleepless nights, pages in the middle of the night, undernourished for the task of the day, and impact of work on professional relationships that really steals from the cognitive load that surgeons carry and that other healthcare professionals must carry in order to do the best job for the people in front of them. And the pressures on the healthcare world were very highlighted during the COVID pandemic, right? So there were 18 months where 55,000 people were leaving the healthcare workforce every month during COVID. You talk about people in custodial staff, respiratory therapists, nurses, MAs, taking that whole group of people involved in healthcare, 55,000 people a month, right? We already have a pipeline problem because the work is hard. There's easier ways to make money, make an impact, do something that lets you travel around the world, enjoy nights, holidays, and weekends, right? So couple the pipeline problem with people leaving, we have a crisis. And you know who is the most affected by the crisis in healthcare? It's people who are vulnerable in our community, right? It's the housing insecure, it's the mental health patients, it's people who don't go see their PCP and are getting cared for on the street. So what am I trying to do at SC? So I'm informing my own personal experience being a general surgery resident and then a cardiothoracic surgery fellow while having 2 kids and a career wife, right? It was tough. And I wasn't ready to accept being that dad your kids don't know, that relationship that falls apart because you're, really focusing on other people rather than yourself and your immediate community. So I borrowed from a lot of research and a lot of policy in other high-performing sectors. So special forces, military, elite athletics, executive leadership, aerospace. There are decades of research around performance science and human factors that I borrowed to experiment with how can I show up in life the way that I want to, as well as in work the way that I want to. And a lot of the stuff that I tried on myself is not rocket surgery. Just no one tells you what to do, how to sleep right, how to eat right, what the power of mindfulness is, how to take care of yourself so that you can take care of others. And over the last couple of years, I've been trying to build and adapt those deep evidence bases from other high-performing sectors to healthcare. So we can support our healthcare providers. They can support themselves. So research to me, just like Ryan here said, can't just be research, right? Numbers can be made to show anything that you want them to. They get interpreted any way you want them to. So in my world, I try to blend what we're learning from the research that we're doing with the implementation that we're designing for the clinicians at the front lines of healthcare. So that our programs, our teachings, our workshops, our initiatives are coupled to the research that we're finding from the people themselves. And I think what Seth and I were riffing on when we had our conversation is there's a lot of correlations there between how do you take real world micro and macro interventions that are not rocket surgery, right? That you can study in unique populations that make a meaningful difference on someone's lived experience in order to improve how they flourish in whatever environment it is, whether it be an operating room or the streets in Los Angeles or in a boardroom. So I really think that using research creatively, borrowing from other people's research and applying it meaningfully and tangibly to the real life experience of people is how you build research into this idea of flourishing, how you teach people to do it in real time. And the thing I'm struggling with now is how do I then take it to policy? So we have a healthcare pipeline problem, right? We are going to be short doctors, nurses, surgeons. So how do we change that? What policies can be brought in to hospitals, to Medicare, Medicaid, to support clinicians and healthcare workers in their ability to take care of themselves so that they're able to take care of everybody else?
Isn't that something? Policy to take care of yourself. I like this flourishing front line that was shared. I think that what if we some kind of way communicated to like frontline workers across the sector, reminding them, encouraging them to take care of their dental, mental, and vision. Right? You're supposed to have a dental checkup every 6 months. Have you been to the dentist this year? Be sure you take time off within this month. We will approve you to go do your dental care, your vision. Be sure you're not missing appointments. Like, as much as we want you here, we don't want you to take off. We actually do because we need you to be flourishing and healthy so that you don't have to take the time off work when you crash, right?
That's right.
Yep.
Time check? Yes, Q&A. Okay, so just before Q&A, I do want to ask, do you have anything? Did we miss anything? From what you can tell, I know you weren't here for the whole day, so the audience, that's your question, but is there anything that you would like to say based on what you've heard other panelists say before we take questions?
I think that it's important to not discount the mind, right? Like in our society, we're extremely focused on efficiencies and tasks and quality, technique. Like that's what I learned in school, right? How can I take out a pair of lungs and sew in a new pair of lungs that work for a patient who needs a lung transplant? I was trained in that really well. I was not trained well about the inner game, right? Like what does it take to be ready for that? What does it take when there's a crisis? How do you remain focused and resilient? But at the same time, how do you manage the million other mental inputs that you're getting from your thoughts and your experiences in your life outside of the operating room? And I think that idea, the importance of the inner game when it comes to human flourishing, is immensely trainable, it's immensely impactful, and it's often misunderstood or misrepresented in how it is brought forward to people who could benefit from understanding their personal identity, values, priorities, and using that to leverage whatever version of performance that they're looking to get.
You make me think that we need to do way better at mental health stigma reduction. We all need to take care of our mental well-being, no matter what, right? And so we know people are traumatized on their way to being homeless while they're homeless, trying to get out of it. Do you think anybody needing help, do you think they may have or have battled with depression, anxiety, PTSD? So why can't we just blanketly and give people the skills? You know, there's skills and there's pills. We'll let the mental health sector take care of the pills part, right? But can't we give people skills to work through their depression, skills to work through their anxiety, skills to work through their PTSD? There's so many curriculums, CBT, DBT, seeking safety. And this is just like we're giving this to people for them to read and them to they can self-discover with that and even work with, you know, someone to help them through these things. But what about the front line? Are they dealing with depression, anxiety, PTSD? You see what I'm saying? So why aren't we just giving them the tools for that? Like, I don't have to tell you have depression, anxiety, PTSD, but because of what we know that you're dealing with, you came from lived experience, you're working on the front line, you're dealing with, this is maybe a re-traumatization. Here's some things that can help you. That's the start. What about fitness, nutrition, hydration, and sleep? Can we just start with that? Sending encouragement out to the sector. How's your fitness, right? Did you know that if you really want to know how your staff is doing, did you know that you can just ask them about their sleep? And it will tell you about their mental well-being and how much they are probably struggling on the job. So we talked about flourishing all day long. What did we miss? That's the question on the table. And also, if you would like to ask a question.
I'd like to talk about something.
Okay.
I don't know that we missed it necessarily. I think it's been alluded to, but I thought it was interesting that heart surgeon talked about the head. I'm going to talk about the heart. So
I love that.
It's giving people permission to love again. And so when we do street medicine, how we try and train our staff is to first deliver an understanding love, and then the same quality of care on the street that you'd expect in a clinic. because how we're trained and how it works, and it's not just medicine, but you're taught no hugging your patients, no crying with your patients, don't get too close. It's going to cloud your clinical judgment. You'll make the wrong decision, and it's unprofessional to do that. And so then you get out into the world and you meet your client or your patient, and you find somebody that's scared and suffering, and you have a choice. Do you engage with them and share with them in that suffering, thereby exposing yourself to maybe some secondary trauma? Or do you retreat in an act of self-preservation? And if you've been trained that the professional thing to do is actually retreat, then you'll do that every time. But when you do that, you leave the person isolated, right, but you've also isolated yourself with the knowledge that you've abandoned the people you've dedicated your life to serving. And so that's what, and when you do that every day for, people in clinical care, it's like 15, 20 times a day you do that for years. And so what we're seeing is there's some burnout, but a lot of it is moral injury from doing that over and over and over again.
For sure.
So to answer the question, I think it's just giving permission to love your patients or love your clients.
And if I can maybe,
Ryan.
And if I could,
Well, I'm not saying you missed it. Maybe I wanted to underscore it.
Yeah, that's right.
Dr. Ryan.
Well, just really quickly, just maybe building on that. Also, I think this is a really good opportunity to double down in community building. So we brought together 100. We were doing some focus grouping for our next iteration, our strategic plan. We brought together 100 of our clients across 75 of our programs to ask them, well, what can we do better? How are things going? And what ended up happening by the end of the time, they said, you know what? This is great. I'm glad you're asking us for feedback, but we like to talk to each other. Like, well, how were you able to access that resource? And how did you navigate that? And let me share why my caseworker is good, and maybe you should sign up with my caseworker. Or actually, if you go to this place, and then by the end of the day, they said, well, why aren't you all creating a space like this so we can talk to each other? Because in this moment, we need community, and we are each other's community. Yes, you are used to being a service provider and giving, but give us space so that we can serve each other. And that was something that was uniquely powerful for us. So where we thought we were going to do some research and some surveying, they said, no. What we need in this moment is for you to help us create community, because it's far too often that not only do we talk about within systems, the left hand, the right hand don't know what they're doing, but within the clients that we serve, they don't have opportunities to actually just communicate with each other. So now we're thinking about how do you create a monthly experience across our 75 programs so that they are helping each other navigate rather than us saying we're the only people who can help you navigate. Yes. And that to me is like the power of how we make connection in this moment. And Winston Churchill says, never waste a good crisis. This is an opportunity to think differently and more effectively about how we build connection amongst populations.
Yeah.
All right.
I think we got time for a couple questions from the audience. Oh, we got one here and one here. Okay.
So I liked particularly, Brett, what you were talking about when you talk about the fact that providers are dealing with a system that's crazy, and it makes it really hard, and it doesn't give them a lot of space to be able to really take care of themselves. And you said, give everyone permission to love their patients and respect their patient. And I'm wondering what other models there might be that we could teach in school or maintain throughout organizations that would be able to help our providers be able to deal with the external systemic things. Because a lot of times, to my knowledge, it's not that people don't know how to take care of themselves. It's really that they're being impinged on by a system that's making that very difficult. Anyone?
Yeah, thank you for that question. Because my work at USC covers medical students all the way up to chairs, right? I tend to spend a lot more time with the boots on the ground residents, right? They're working 110 hours a week in the hospital. And I tell them to do something like work out, sleep better, have a healthy hot meal, and they're like, dude, what? When? Grabbing saltines from the break room, right? And so I talk to them about micros and macros. So, and the way I'm going to answer your question is there are ways that you need to figure out how to teach people to integrate some of these best practices for performance and flourishing into their normal day, right? Don't make it another box to check, because that's just more hard, right? So a example, take the stairs, right? If you want to be someone who works out or values fitness or thinks that's important for your psychological health, just take the stairs. There's actually studies to back up increase in VO2 max and maximal force plate generation if you take the stairs instead of the elevator. You're not adding to your day. You're not adding to a box. You've just made an informed decision to do something in the confines of the system that you find yourself in. So that's the crux of my work with this, is to try to figure out how do we find micros? How do we use empty space? Waiting for anesthesia to put in an A-line during a case. That's 10, 12 minutes. You could do something. You could do 8 minutes of mindfulness practice or gratitude, or you can write in a journal, or you can reflect about the case you're about to do and kind of get yourself on the right level. How do you find the micros? And then when you have time, where can we add in some macros? So sleep consistency, nutrition, bigger fitness than taking the stairs. But there's ways that we have to work within these systems which are harder to move. They're boulders in the trail, not a pebble in your shoe. We need to find the pebbles in the shoe, get rid of them in the short term, and in the long term, we'll use research and policy to try to get that boulder out of the way, or provide opportunity for these macro behaviors that are beneficial.
Thank you very much. Do we have a...
Okay. I just want to induce a bio with Healthcare in Action. I'm a colleague of Brett Feldman's in Street Medicine. I just want to double down on what Dr. Smith, you said about the forum where the people you serve came together and said, why aren't we talking to each other more? So I'm on this phone call like yesterday with the Measure A county-driven community engagement forum, and there's 122 providers on the phone call. And they put up these slides being like, well, there's just not going to be enough funding. We're just going to cut. Their cuts are coming. The cuts are coming. And give us feedback on like which cuts you want and which cuts you don't want. And they literally listed all of our organizations on there, right? And what I felt in the room, and Carrie Morrison was on this call with me, what I felt in the room, and everybody started, speaking up a little bit here and there, the 122 people. And it's like, what you heard was, don't give me your thing to react to. Do you know what I mean? Don't give me like the pre-planned decision and I've got to give input. Let me make it with my colleagues first, and then we'll get back to you. And we'll probably prove that you don't have to cut, funds for ICMS. Maybe we have to reorganize ourselves differently. Maybe if we collaborate, between ourselves, we're not going to have to just take what you're saying and take funding cuts. So I was really a little put off by this idea that policymakers with our money that we've raised for Measure A are like unilaterally telling us, you're going to have cuts. You're going to have to lay off staff. What do you think about this? And it's like, no, maybe we don't. So anyway, just wanted the forum for us as providers to influence back up again the way the people you serve were asking for.
Yeah, I love that. And I think people often forget that, problem solving really happens on the ground. Like, I think about history. It wasn't a system leader that created the Underground Railroad. It was people talking to people that help people become free. So when there is a big problem, like we're going to have massive cuts, why don't we start with not, and I thank our system leaders for bringing people together, but we'll start like, well, what have you been learning is most effective on the ground? How are you thinking about using resources differently in this moment? And I think we need more space for that. And what I love about what the research that Seth is doing here, it's really about how does flourishing happen in systems, and that starts with people, right? That does not start with system leaders. So I think in this moment where we're talking about cuts, can we create space differently? So maybe there's an opportunity to think that together. So appreciate that.
I appreciate the discussion. Do we have time for something else? While the mic is being handed, I think Joe had a hand up.
Yeah, I saw Joe's hand. We are at time because we want to.
We're at time.
Our last element and get folks out of here.
I would like to shut us down, our panel. Okay. Thank you, Sawaba. Thank you, Brett. I can call him Ryan. Thank you, Dr. Smith. Thank you, Graham, Dr. Graham. And I'm gonna put another word on your brain as we leave in the frame of love and belonging. Add mercy. The work we are doing is merciful. Any blocks or negative talk about funding cuts or housing first and all that, whatever the negative talk is, just know that is merciless talk, right? If we are to do unto others as we would want someone to do unto us, right? If we are to love our neighbor as ourselves, that is called mercy. You don't walk by the person, you help them up. That's what mercy is. And what Brett talked about is something called emotional CPR. If you don't know what that is, just like you can resuscitate a person's heart physically, you can resuscitate them emotionally by being with them and not doing that cut off. And there's a whole teaching on it. I would love to bring emotional CPR to the sector. But until then, go with mercy.
Amen.